Welcome to the webinar, The Challenges of Lyme Disease, from Clinical Diagnosis to Testing Methodology, sponsored by Merieux. The first presenter of today's webinar is Kent Lewandowski. Dr. Lewandowski is an Associate Chief for Laboratory and Molecular Medicine at Massachusetts General Hospital. He is also a Professor of Pathology at Harvard Medical School with research interests in pancreatic pathology and the evolution of point-of-care technologies. His training was in anatomic and clinical pathology at Massachusetts General Hospital, and he has been on staff in the Department of Pathology since 1991. Additionally, he is the editor-in-chief of the medical journal Point of Care, the Journal of Near-Patient Testing Technology. The second presenter of today's webinar is Lena Prisco. Dr. Prisco holds a PhD in pharmacology from the University of Connecticut and is the Medical Operations Director of Vineyard Medical Care and the Principal Investigator of the Vineyard Center for Clinical Research. She has over 18 years of experience in the pharmaceutical industry, in research, drug discovery, clinical trials, and medical education. From 1998 to 2009, Dr. Prisco was an adjunct professor in the Biology and Health Sciences departments at Quinnipiac University. She was the former laboratory director of Martha's Vineyard Hospital from 2010 to 2014, holds a master's degree in laboratory diagnostics and clinical biochemistry, is certified in clinical laboratory science, and is a College of American Pathologists and CLIA certified laboratory director. Additionally, Dr. Prisco works on the Island Boards of Health Tick-Borne Disease Education Committee, and she has been a full-time island resident of Oak Bluffs for the past 7 years. Thanks again for joining us for today's webinar. At this point, I'll turn our presentation over to our first presenter, Dr. Lewandowski.
Thank you for the introduction. Now we have the mechanics of the webinar worked out. I wanted to also thank our sponsors for bringing us all together today to talk about a topic that is emerging and on a national level is becoming an increasing problem within infectious disease and laboratory medicine. And I wanted to thank the audience for joining us as well. I hope you find the presentation interesting and informative. First, a statement on conflicts of interest. I have no conflicts of interest to declare, and as well, I'm not going to be getting an honorarium for this presentation. As many of you know, Lyme disease is a tick-borne infection caused by 3 species of Borrelia burgdorferi sensu lato. In the United States, the principal culprit is Borrelia burgdorferi sensu stricto, whereas in Europe there are 2 additional species, as shown on the slide here, B. afzelii and B. guerinii, but also there is some sensu stricto in Europe as well. Of note, many strains of B. burgdorferi exist in the United States. Currently, there are 23 identified OPC types with variable geographic distribution. And the issue of these multiple strains is beginning to be recognized as problematic in some areas of diagnosis, as well as they may vary in their clinical presentation somewhat. Lyme disease reported cases. This slide is from the CDC. It shows cases reported in 2001 versus 2003 across the United States. You can see simply by the concentration of dots that a lot more cases are occurring in the present time than in the past. So it's a disease that's increasing significantly in prevalence. Also, on a national level, it was traditionally viewed as a disease that occurred in the Northeast and Great Lakes region. But if you look at the distribution of dots, you'll see that almost every state in the country has reported cases of Lyme disease, and it's increasing on the national scope. Lyme disease reported cases per year. This was the traditional viewpoint. This is from the CDC. The conventional wisdom was that there were about roughly 30,000 cases of Lyme disease per year in the United States. And this was based upon confirmed cases as well as cases that were considered probable, as shown on the graph on this slide. So you can see a steady increase in the number of reported cases of Lyme disease. But still, at the time, up until recently, Lyme was principally viewed as a disease that's relatively uncommon, principally geographically restricted, and traditionally viewed as readily treatable with a short course of antibiotics. However, many cases go unreported. The CDC recognized that their system for surveillance was not adequate to fully appreciate the extent of Lyme disease within the country, and so they embarked in 2013 on an attempt to better estimate the true incidence of Lyme disease. They had to do this through a somewhat unconventional method, but nonetheless they managed to come up with a reasonable estimate. They performed a survey of 7 national reference laboratories reviewing Lyme disease testing. They also reviewed insurance claims as well as performed a patient survey. But when all was said and done, their new estimate in 2013 came out to 300,000 cases of Lyme disease per year across the United States, so fully 10 times what was previously recognized. So Lyme disease has gone from this relatively low incidence, geographically restricted disease to one that is national, increasing in incidence, and hundreds of thousands of patients are now affected by it. Lyme disease is typically seasonal, depending, of course, on your local climate. In New England, we have very, very cold winters, so we don't see too many cases of Lyme disease in the depths of winter. Some of these are individuals who were infected earlier in the year and are coming with a later stage of presentation. But most of the tick-borne diseases are as seasonal, as shown in this graph, looking at number of cases over the course of the months throughout the year. Of course, this is skewed by the fact that in New England, where many cases of Lyme occur, we have a very seasonal aspect to the prevalence of the disease. But in different states with different climates, the figures may be somewhat different. Life cycle of the deer tick. These are complicated little organisms. The Ixodes scapularis, aka black-legged tick, is the principal culprit. It starts out with tick eggs, which then hatch into larvae, and the larvae then feed, so-called meal one, typically on a mouse, a bird, or some other mammal. The larvae then molt into a nymph stage, and ultimately the nymphs go dormant during the course of the winter, and then they reemerge in the spring, and that's when they can take a second meal, which may involve other animals, but at this point people as well. The nymphs then can molt into adults, which may eat second or third meals, and then subsequently the adults die and they lay their eggs, and the cycle starts all over again. So there are multiple stages in the life cycle, multiple feedings that may occur, but humans are one part of that overall life cycle. Lyme disease occurs in different stages if it's not treated. Stage 1, so-called early localized disease, is characterized by the typical Erythema migrans rash. This occurs usually 3 to 30 days after the bite, with a mean of about 7 days. It has a very typical target-like appearance and is seen in the majority, 70 to 80% of patients with Lyme disease. However, it's important to note that not all patients with Lyme disease exhibit the rash, but when it's present along with characteristic flu-like symptoms such as fatigue, headache, lymphadenopathy, fever, chills, myalgias, which means muscle pains, or arthralgias, joint pains, you can make a clinical diagnosis. So if you have typical symptoms, typical erythema migrans, rash, history of exposure to a tick bite, you don't need to do Lyme testing at that point. You can treat the patient presumptively without further laboratory testing. This slide shows a typical picture of the Erythema migrans rash. The target-like appearance of the rash may occur anywhere in the body. Over time, it gradually expands in size. However, as I mentioned, it's not always present on patients, or it may be hidden, such as a rash that occurs on the scalp or on the back that the patient didn't notice. It's not painful or itchy, and it may feel a little bit warm, but other than that, if it's in a hidden location, the patient may be unaware that they ever had the rash. After stage 1 is the early disseminated, or stage 2 component of infection, occurs days to weeks after the tick bite, and it's characterized by spread of the infection from the site of the bite. It may occur in untreated cases of Lyme disease from stage 1. Typically, the signs and symptoms include multiple erythema migrans rashes, which can occur all over the body in large numbers. Patients may exhibit neurologic involvement, such as lymphocytic meningitis, cranial nerve palsies, especially Bell's palsy of the facial nerve, which is a characteristic. A patient wakes up and suddenly they have facial droop on one side of their face. Spinal nerve radiculitis, either sensory or motor neuropathies, and mononeuropathy multiplex. Rarely, but occasionally, Lyme carditis will occur where you have infection involving the heart, which may present with AV nodal block on electrocardiogram. And then finally, Lyme arthritis with joint pain or swelling, which most typically occurs on the knees, but not invariably. This slide shows the relative frequency of the different presentations of Lyme disease. Again, Erythema migrans, fully 70 to 80% of patients will show that. Arthritis will be seen in up to 30%, Bell's palsy with facial droop, 8%, and other CNS findings in a minority of patients. And finally, a very distinct minority of patients will exhibit cardiac involvement, roughly 1%. So the presentation may involve a number of different systems in the body, whether it's the rash, whether it's arthritis, neurologic findings, or cardiac. Lyme carditis is rare, but there have been recent cases in which patients have experienced sudden death, presumably due to complete heart block. The most common manifestation of Lyme carditis is atrioventricular block, which is characterized on ECG by a prolonged PR interval, and in some patients, P waves without showing conduction. So if you look at the EKG, you start with the P wave, and then you have the QRS complex, as shown by the arrow here. And the distance from the P to the R is the PR interval. And if you look at the heartbeats across this ECG, you'll see that the PR interval is varied and extended. In some cases, as I'm highlighting here with the arrow, the P wave is not followed by a QRS complex at all. So the P wave has been blocked from causing cardiac contraction. So uncommon Lyme carditis, but it has been identified as a cause of sudden death in a very, very small number of patients. Continuing on with the stages of Lyme disease, late disseminated Lyme disease. This can occur months to years after a bite, and according to the CDC, it'll occur in approximately 60% of patients who haven't been adequately treated. It's characterized by recurring episodes of arthritis with joint pain and swelling, and a minority of patients will have chronic neurological symptoms, including nerve pain, paresthesias, which is a pins and needles feeling, and patients may have cognitive and memory deficits as well. And this late-stage Lyme disease can be quite debilitating, particularly in patients who have nerve findings and cognitive memory problems as well. So some of these patients end up ultimately disabled. Then there's recognized another stage of Lyme disease, and I think this was something that 10 years ago people didn't really think much about, but it's become apparent that there is this condition called post-treatment Lyme syndrome. It occurs in about 10% of patients who are adequately treated by current Infectious Disease Society America guidelines, and these patients show variable persistent symptoms such as fatigue, joint pain, muscle pain, insomnia, and again, memory and cognitive symptoms. These can be mild or they can be sufficiently severe to leave the patient disabled, unable to work, and with significant life impairment. So post-treatment Lyme syndrome is a significant problem for the patients, occurring in 10% of patients. If there are 300,000 cases, you have 30,000 cases of post-treatment Lyme syndrome across the country in any given year. So because of the increasing incidence of Lyme disease, post-treatment Lyme syndrome is becoming a greater and greater problem. However, if you look at these symptoms, fatigue, joint pain, muscle pain, sleep disturbances, cognitive problems, these symptoms overlap with a number of other conditions such as fibromyalgia syndrome, etc. So not all patients who've had Lyme who subsequently get these symptoms is it due to a post-treatment Lyme syndrome, but be aware that it may be. Many of the patients also exhibit autoantibodies, including positive rheumatoid factor, anti-nuclear antibody, anti-cardiolipin antibody, and the like. And some of the aspects of autoimmunity are thought to play a role potentially in the post-treatment Lyme syndrome. The cause of post-treatment Lyme syndrome is not completely understood. It's very controversial, and it's become a very polarized debate. And so this whole topic of post-treatment Lyme is something that's a very hot-button issue among a number of people. And I don't personally feel qualified to judge the debate to say one way or another which is the correct interpretation of the data that we have, but I have to acknowledge it because it is a very important issue that is taking place on a national level. What causes it? It may represent an autoimmune reaction caused by the Borrelia infection, and it's known that a number of infectious agents can induce autoimmunity, so this wouldn't be necessarily unique to Lyme. It may represent persistent inflammation or perhaps immune dysregulation, and there are some people who think that chronic infection is the cause of post-treatment Lyme syndrome, although that's never been proven. It hasn't been completely disproven either. So we have this group of patients. They're significant in terms of their number. They have significant disability and ongoing symptoms. And as of the moment, nobody really knows what's going on with them, and as a consequence, how best to treat them and bring them back to health. But it's a growing problem on the national level. Lyme disease treatment and prevention. Treatment is also controversial and polarized, much like the post-treatment Lyme syndrome. And again, I'm not going to come down and make a statement to judge this debate. I think I'll leave that more in the realm of the public sector between medical societies, physicians, and others. But I will present some guidelines here that are abstracted from the Infectious Disease Society of America guidelines, which gives you at least one approach that is standardized and recognized within medicine. But there are other guidelines that exist, and I don't want to discount them. I'll simply acknowledge that they exist. So Lyme disease prevention. The first step in prevention is not to get bitten by a tick in the first place. And this can be accomplished with variable degrees of success by avoiding areas that contain ticks, such as woods, unmowed grassy areas, and the like. About a week ago, I was out cleaning brush within nearby my house, and I took very great care not to go wandering into all the bushes and tall grass, hoping to avoid getting bitten in the first place. Perform frequent tick checks. So you have to look very, very carefully. The ticks are very, very small. They're easily missed. So you want to do a careful examination of yourself for ticks. Employ protective clothing. So I was not running around in topless and in shorts. Rather, I wore a long-sleeve shirt, tucked in my pants around my socks to try to provide some kind of barrier function. Employ insect repellents, such as DEET, to keep the ticks away from you. And after returning from an area, perform again a thorough tick check and take a nice shower, which after I was working in the brush for hours in the heat was not something that I found hard to do. And finally, the clothes you take off, decontaminate them. You can do this by putting them in a hot dryer, for example, because you don't want to bring the ticks into the house. You avoid getting bitten outside, and then they crawl into your bed during the evening. Okay, so you've done all this, and lo and behold, you find you have a tick. And this shows the CDC recommendations for the correct method of removing a tick. You don't simply grab it with your fingers and give it a yank. That's not the best way to approach the problem. CDC recommends using tweezers, and you grab the tick close to the skin, as shown in the little cartoon, and then pull upward with a steady pressure, not a quick yank, but slowly pull the tick until they let go. Clean the area with rubbing alcohol, iodine scrub, or salt and water. And then remember, of course, to kill the tick. You can do this by immersing it in isopropyl alcohol, or you can flush it down the toilet as one alternative. And you're cautioned not to try to crush the tick with your fingers. So if you have a tick, remove it properly. Well, you had a tick and you didn't get to it in time, and the tick is big and engorged, and you're wondering, is there anything you can do to prevent getting Lyme disease now that you've already been bitten? And there are some thoughts about how to approach prophylaxis following a tick bite using antimicrobial therapy. The standard guidelines are that antimicrobial prophylaxis is most appropriate if the bite is due to a known adult or nymph Ixodes scapularis tick, if the tick was attached for an extended period of time, such as greater than 36 hours, from a known time of exposure, or if the tick is significantly engorged, that would suggest that it's been hanging on to you for some time. The guidelines also recommend that prophylaxis be used if local ticks exhibit a greater than 20% risk of infection themselves. So if this information is known within your locality, that's helpful, but if it isn't known, then it's not too practical. And also the patient should not have contraindications to the use of the antibiotic. And there are different protocols, but a doxycycline 200 milligrams single dose is one of the recommended prophylaxis for tick bites. How often you use prophylaxis is going to vary by different physicians, vary by different patient preferences, but these are some general guidelines, but they're not absolute. Treatment of Lyme disease. For stage 1 Lyme disease, Generally speaking, the majority of patients will get better with oral antibiotics. The first-line drug is oral doxycycline, but in selected patients, amoxicillin or cefuroxime can also be used. Of note, doxycycline is not recommended for children less than 8 years. And if you have some doxycycline in your house, please don't decide to freelance it and give it to small children. As I mentioned, most patients will get better with oral antibiotics, but be aware 10% of them that get the post-treatment Lyme syndrome will have persistent symptoms. Relapse can occur, requiring a second course of antibiotics, and in some cases, relapses will occur because the patients don't necessarily follow their physician's instructions. So they start the antibiotics, they're starting to feel better, they skip doses, they stop taking them, and then they get a relapse. One phenomenon that's worth noting in patients who are treated with Lyme disease is that they may initially, within the first 24 hours, exhibit a worsening of their symptoms. This is a phenomenon known as the Jarisch-Herxheimer reaction, which is presumably due to release of inflammatory cytokines and release of products from the killed bacteria. So when patients are going to be treated, the doctors should warn them to say, look, you may over the next day or so actually feel worse, but that'll be a transient effect that'll wear off fairly quickly. Treatment of more advanced stages of Lyme disease, including neurological and cardiac manifestations and arthritis. Infectious Disease Society guidelines are posted online, so they're easily accessible. There are different protocols depending on the individual patient that include both oral as well as parenteral antibiotic regimens depending on the individual patient. For the parenteral route, the generally preferred antibiotic is ceftriaxone. However, there are some other regimens. The problem with giving parenteral antibiotics, is you have to maintain access to the venous system, which is usually accomplished with a so-called PICC line, or peripherally inserted central catheter. These generally are tolerated very well, and they allow a patient to self-administer antibiotics in the home, which makes it convenient for the patient. However, be aware PICC lines do have an irreducible complication rate. It's small, but nonetheless, you can get thrombosis of the vein. You may get embolus when thromboses break off. The site may become infected. You may get phlebitis, or malposition of the PICC lines can be potential complications. So you don't just put a PICC line into somebody without really thinking through what the benefit is going to be for the patient. So that's tick and Lyme disease, but it's increasingly recognized there are many other tick-borne infections, and these will vary geographically depending where you are in the country. And this list continues to expand. Anaplasmosis and ehrlichiosis are tick-borne infections. A relatively new Borrelia species, Borrelia miyamotoi, has been expanding significantly in New England. And then there are Borrelia other than Burgdorferi, for example, B. hermsii, which is seen in certain parts of the country. Babesiosis, we see lots and lots of babesiosis in New England and increasing all the time. Last summer I was in on a Saturday, and we had 2 cases of babesiosis during one morning from our emergency room. Then there's a whole list of additional tick-borne illnesses: Colorado tick fever, Powassan virus, Starry heartland virus, and so on and so forth as listed here. And new things are being discovered relatively frequently. So the list of tick-borne infections that are potential problems is not fixed. It's changing over time. And also the geography is starting to change. And so you have to keep up to date with what are potential infectious agents within your area. One tick-borne or potential tick-borne infection that's somewhat controversial is Bartonella. Some people believe this is a tick-borne infection. Others do not feel there's any clear evidence that it's transmitted by ticks. So that's one that's controversial at this stage. And again, I'm not going to come down with a flat statement one way or another. I just want to acknowledge that it's there. You'll see it if you look on online forums. There's controversy about whether it really is tick-borne or not, and you'll have to make that decision for yourself. With these other tick-borne infections, like Lyme disease, they have different geographic distributions. Be aware they can occur singly, so you can have anaplasmosis or ehrlichiosis, or you can have co-infections. So a patient who has Lyme disease can also have babesiosis or also have anaplasmosis. So you're not always dealing with just one single tick-borne infection. There may be more than one. Some of these are relatively geographically restricted. For example, Borrelia hermsii is seen in the western U.S. and southern British Columbia and Canada, whereas babesiosis mainly occurs in the Northeast and the upper Midwest. So depending on where you are in the country, the potentially likely culprits are going to vary somewhat. This chart is from the CDC. It shows the distribution of ehrlichiosis in the United States. And interestingly, I'm from Massachusetts, so I'm pointing out our tiny little state here. We very, very rarely see ehrlichiosis in Massachusetts, whereas in adjoining states, New York, Vermont, Maine, New Jersey, not far away, it's something that you see with some degree of frequency. So geography is important, and it's also changing. So the fact that we don't have ehrlichiosis in any significant number in the United States doesn't mean 5 or 10 years from now it's not going to be seen with a greater frequency. Just wanted to highlight one recently discovered tick-borne infection, Borrelia miyamotoi. It's an emerging tick-borne infection in the northeastern U.S. We're seeing more and more of it. It was first reported in the United States in 2013, and its presentation is somewhat different from typical Lyme. Patients often have nonspecific symptoms of recurring fever, headache, chills, arthralgia, and myalgia. The diagnosis is based on clinical manifestations, and at present there's a polymerase chain reaction test. But I think going forward in the next year or two, you'll start to see some other tests being offered as laboratories catch up and develop assays for this new tick-borne infection. So some general conclusions. Lyme disease occurs across the United States with a concentration in the Northeast and Great Lakes region. It also occurs across Europe and other countries. The estimated number of cases annually is increasing rapidly, and it now is about 300,000 cases per year in the United States. Prevention is the first line of defense. If you can avoid getting bitten in the first place, then you probably are not going to have a great likelihood of getting Lyme. Lyme occurs in several stages. Most patients will get better with a standard course of antimicrobial therapy. However, some will have a recurrence requiring the need for a second treatment, and about 10% will get the post-treatment Lyme syndrome, which is a significant cause of morbidity and disability. And given the increasing incidence of Lyme disease, PTLD is becoming a greater and greater public health problem. The cause of post-treatment Lyme disease is poorly understood and is controversial, and nobody clearly understands what is making these patients ill, at least as of the time being. There are many other tick-borne infections that vary in frequency and by geographic region. They may occur by themselves or they may occur as co-infections with Lyme disease. And be aware, new tick-borne infections are being recognized all the time, so the state of knowledge today, this summer or this fall, yet another tick-borne illness may be discovered. So I wanted to conclude the talk by thanking you for listening to my presentation. And this slide here shows the ether dome at Mass General Hospital, where ether as an anesthetic was first demonstrated some time in the 18th century. Back then, they didn't even know about Lyme disease, and they didn't have antimicrobial agents to treat it if they did know about it. And it sort of reminds me of how medicine evolves over the time. As we go from century to century, decade to decade, year to year, new knowledge, new discoveries bring new light about what can occur in the medical field. And tick-borne infections is an evolving area of medicine. There are controversies, and it's affecting a large number of people in the United States. So it's important, and it's something that is a story that continues to unfold. And with that, I'll thank you and turn it over to our host.
Thanks, Dr. Lewandowski. At this time, Dr. Prisco is going to continue the presentation.
Good afternoon, and again, I'd like to thank you for attending this presentation. I'd actually like to back up for a minute and re-show this slide that Dr. Lewandowski presented. While I agree that, in terms of CDC symptoms, etc., the rash is in a high incidence. Here in particular on Martha's Vineyard, where we have a very high infection rate, actually, of both Lyme and babesiosis, we see less of this particular patients presenting with the rash than we do with the general symptoms of arthritis, the myalgias, the fatigue, they know they've been bitten. We get a lot of tick-borne fever and more flu-like symptoms. That could be more likely due to there is a very high awareness here that Lyme is very prevalent and to come in right away and get treated. So we may be catching these people before the rash actually develops, which can take some time. And it could also be due to the fact that the CDC really considers the rash, the EM rash, as the basic confirmed way of that is how they have a confirmed case of Lyme beyond a positive laboratory diagnosis. So those are a couple of things to keep in mind. It's not always as simple as somebody's going to come in and have that nice bullseye rash. The rashes can be very diffuse, as well as the symptoms can be very diffuse. So keep that in mind as we start talking about laboratory diagnosis. So the CDC recommends this two-step approach, which I'm sure most of you know. Use an ELISA serology screening assay. And it comes down to this tiered testing. If it's positive or equivocal, they recommend a Western blot looking for both IgM and IgG specific antigens and antibodies. If it's negative, you report it as negative and you don't do any further testing. However, there are times where people present early enough and the specific antibodies have not risen to the level of detection, and they may still have symptoms. So if the disease duration is short, they recommend the patient return after 14 or 21 days so that you don't want to miss these patients at all. So again, if it's positive, you report it as positive. The definition of positive in the Western blot arena, whether or not you had a positive or equivocal screen, is you need at least 5 bands in the IgG blot and at least 2 or more in the IgM blot. And there are cases where you do a Western blot and it doesn't reach the level of positivity, and that should be reported as negative. And again, that can be because the disease duration has been short, and you can redo it at 14 to 21 days. And again, I'd like to recommend that and remind everyone that this is the CDC approach, and sometimes that's hard to meld it with the patient that you have sitting in front of you, that your gut is telling you that this patient has Lyme disease based on a host of symptoms. Now, if they have the rash, as Kent had mentioned, it's pretty much game over. There's really no need to test. You can just go ahead and generally those patients are treated immediately. So when we talk about Western blots, interpreting the results can also be a little convoluted and difficult at times. So again, I said in the typical positive, you have at least 2 bands, and then you're looking at the IgG response as well, and in this case, if I'm looking in the top box, you have less than 5 bands. The interpretation is generally thought that this is early disease. It's been less than 4 weeks. It can also be interpreted that this is a past treated infection of greater than 4 weeks. Now, that opens up a whole host of do I treat, do I not treat, and that really gets back to Kent's, Dr. Lewandowski's point about your location. If generally in our clinic, because we are in such an endemic area, and we know that people come in and are basically reinfected many times over a summer, we really use that information in a much more broader and conservative approach, and would most likely in this case say we're going to fall on the side that this patient has early disease, particularly if they're presenting with any other types of symptoms, and they would be treated. In the second scenario, you have an equivocal or positive serology, a total serology, and it's negative in the IgM. There are less than 2 bands, but the IgG blot is positive. This can be a couple of things. It can be a past-treated infection in the most strictest sense of the term, but it could also be that that patient has undergone what's called seroconversion. They've now come in later, and a lot of their IgM response has seroconverted to an IgG antibody, so they are in the throes of infection. And if that is the case, these patients would absolutely have symptoms and may or may not have a rash, but they should at least have frank, what you would call Lyme symptoms. The myalgia is probably some type of arthritis, etc. In the third column, you'll see positive, and positive, obviously, that's active infection, and seroconversion has already started. That's pretty easy to interpret. And in the last one, we have a negative, less than 2 bands, and negative in the blot, less than 5 bands, and that is negative interpretation all the way around, some past exposure or past treated infection. However, there are many patients that we do see here on Martha's Vineyard that have this type of serology. So again, I want to emphasize that all of this information has to be taken into the contents of the clinical presentation in the history, where you're located, and what the patient is telling you, what they're feeling, etc. So when do you do laboratory testing? You can stick to the strict CDC guidelines. It should be tested to support a clinical diagnosis. Generally not recommended when a patient doesn't have any symptoms, they're not, haven't had any exposure history, and they're from a non-endemic region. The serology really isn't going to give you much information at that point. However, if you suspect some type of infection, you can use the serology to detect disease based on the CDC guidance, treat based on symptoms, obviously, and remember that the response may be blunted up to 70% if that patient has already been treated with antibiotics, which is very common here on Martha's Vineyard. There are lots of people, as Kent had alluded to, who walk around with doxycycline in their medicine cabinet in case they think they've been bitten. They pop a couple of 200 milligram doses and then come in to be treated because they're still not feeling well, and then your serology can become difficult to interpret because that you've already started down the cascade of blunting the response that you're trying to measure. You may monitor for change in response. A convalescent specimen after 6 weeks can be useful. However, I mean, I have to admit it's pretty rare that we ever have anyone come back in unless they're still not feeling well. We may or may not take a convalescent specimen to see whether or not seroconversion has gone on, etc. But usually you would just continue to treat the patient. So this brings us to the Merieux validation and correlation study of the current Lyme assay, which is a total IgG-IgM assay, versus the separate assay of looking at Lyme IgG antibodies and Lyme IgM antibodies separately, and evaluating these assays not only against each other, but also against the Western blot results. And I think what you'll see is actually quite encouraging, and what this would mean to the current state of testing that we have available in our hands. Now, as Kent alluded to, there are lots of newer assays and hopefully better assays all the way around. in development, but we're not quite there yet. So what did we do? We used the platform of the VITUS that has the LYT, for those of you who are familiar with the VITUS, the total serology that's available. Then the IgG, LYG, and the LYM assays. It's highly automated. It's qualitative. All of these assays initially give you a positive, negative, or equivocal response using the enzyme-linked fluorescein alpha, looking for IgG and IgM antibodies to the Borrelia burgdorferi in serum or plasma. The primary objective of this was to do, as I said, a method comparison between the separate antibodies, IgM and IgG assays, versus the total combination assay that is currently available and that most of us are using. And secondarily, to ask if the separate measurements of IgG and IgM antibodies done as a first tier would result in any reduction in actually having to do Western blot assays or give you any additional clinical information that would be useful in the serologic diagnosis of Lyme disease before you go to Western blot, in other words. So we took previously frozen samples from patients with signs and symptoms of Lyme disease. Now, some of those patients were known positive in the total Lyme assay. Some of them were negatives. But overall, we used 114 samples. They were analyzed at the same time in the total assay, and then the separate Lyme IgG and the Lyme IgM assay. All positives and equivocals in any assay were then analyzed using the standard Western blot analysis. The percentages of the separate assay results versus the Western blot assay results were estimated, so they were looked at against Western blot. The same was done for the total assay. So, and that was all done by Fisher's exact test to determine significant differences between proportion of assay results. So basically what we were really trying to focus in on is correlation between using a total assay and a Western blot, and then using these separate assays and the Western blot, and which assay would give you information that was closer to what you would see in a Western blot response. Now, I'd like to say a little caveat here that the total, this does not mean that looking at this type of assay and using the total is any better or any worse. The idea was to see if we could improve upon what we had based on looking at the separate assays first, so that you would know sooner the actual IgG and IgM responses, rather than knowing, okay, I have something here, but I'm not sure which ones I have. So here's what we found. If you look at the amount of times, and I'm actually going to focus on the lower bar first, on the total assay. If you look at the amount of times, so this is how many times did we have a positive or equivocal that we had to do a Western blot. Of the samples that were tested, it was required 180 times. How many times was that Western blot actually positive? It was a little under half, so about 42% of the time were the results confirmed by Western blot for the total assay. If you look at now then testing the percentage of IgG and IgM antibodies in a separate assay, running them side by side, in those that were required, Western blot required, of the 73, 66% of them were actually positive, so your results were confirmed a little over 90% of the time, and in the separate IgM assay of the 65 that required a Western blot, 48 of those were positive, so you still had a pretty significant correlation being confirmed by Western blot. So, basically, why is that important? It's important because it gives you a higher correlation between the VIDAS assays in terms of positives and negatives. So what was important to note was that there was a very high correlation between whether we used the total assay or the separate IgG or IgM assays. Those that were positive in the total were also positive in the separate assays, and vice versa. So it's not as if using the total assay you were going to miss one that may have been picked up if you ran the separate assays. The percentages of the IgG assay results and the IgM assay results that were confirmed by Western blot were statistically significantly high. In comparison, the percentage of the total assay was about 42%. So about half of what you would see if you used the separate assays. What does that really all mean when you get down and you want an immediate diagnosis for a patient who's sitting in front of you? What it really shows you is there was about a 23% reduction in the number of Western blots needed to definitively determine that the Lyme diagnosis was real, that you knew that, okay, I definitely have both antibodies here, and the correlation with the Western blot was high enough to suggest that there may be times in some patients with particular signs and symptoms of Lyme disease that you may not consider and want or have to do a Western blot assay. In our laboratory and in our clinic in our hands, we still do the Western blot, but this allows us to provide our caregivers and our providers more information quickly that they wouldn't have otherwise. So, I'd like to wrap up quickly by saying, per the CDC guidance, laboratory diagnostic confirmation of Lyme disease requires this analysis of IgG and IgM antibodies. Currently available testing utilizes the reporting of the total response followed by a Western blot. Using this VIDAS separate assays provided an earlier laboratory diagnosis that was closer to that is provided by a Western blot. The individual assays used in combination have the potential to provide a clinical impact by providing more information earlier in the disease course rather than waiting for, because most of us have to send our Western blots out, and if you're lucky enough and you're in an area where you can get a Western blot, you're still probably looking at least a 12 to 24-hour lead time before you get this information. So there are significant effects on turnaround time that are important. There are benefits to using these recombinant proteins in the separate assay. And these newer assays also target the C6 region. That has also become important for those of you who also use the C6 peptide assay. So, and like I said, I'd like to reiterate, it's not that the older serologies are substandard in any way. They still obviously provide valuable information. These assays are now the second generation that provide you with more information sooner.